All right, good morning, everybody. Good evening. I don't know where you are watching this. It's morning here in the Bay Area, and I'm excited to take you through egg freezing. If, when, how, and how many eggs does it take? I'm Eduardo Hariton. I'm a reproductive endocrinologist at the Reproductive Science Center in the Bay Area, part of the US Fertility Network. So let's get started. So today we're going to talk about when it's the right time to consider egg freezing, who's the ideal candidate for egg freezing, what does it take, or what does the egg freezing process look like? And then how many eggs does one need to freeze, and what's the expected outcome of those eggs? We'll start with some normal reproductive anatomy. So here you see a brain, and within that, the pituitary gland, which is kind of the master of the reproductive system. It talks to the ovaries. To get pregnant, you need an ovary that makes an egg, fallopian tubes that bring that egg into the uterus, a uterus that works, and then, of course, sperm, which a male partner will provide, or a male donor. In a normal menstrual cycle, your pituitary gland talks to your ovaries. You make one dominant follicle, and then there's a feedback loop that happens. And you can see here, throughout the cycle, you have estrogen, a hormone called FSH, follicle stimulating hormone, luteinizing hormone, or LH, and progesterone, all playing different roles. And you can see down here, this is what happens at the uterus level. You see that first you shed your lining, that's your period, and then that grows over time, gets organized in different ways, ready to receive a pregnancy. And that happens every month through your reproductive lifespan. So what happens with fertility over time? So fertility, as you may have heard, declines with age for females. And you can see in your early to mid 20s, you have about a 25 to 20% chance of getting pregnant each month that you try. And that goes down through your 30s into your 40s when that chance is less than 5%. You can see here the main reason why this happens is that the proportion of normal embryos that you have goes down over time. So you can see here on the left side, abnormal embryos go up and start to take a pretty steep upward turn in your late 30s into your early 40s, going from about 1 in 3 embryos being abnormal in your early 30s to almost 90% being abnormal after 45. And this is just the inverse of that curve. You're left with a small proportion of normal embryos as you get into your 40s. And that's what we call the egg quality, or the egg ploidy, the number of normal chromosomes. That leads the miscarriage rates to go up significantly through your reproductive lifespan. So you can see here, this steep curve correlates to the genetics of the embryo, because that's really the main driver that you're seeing here. So you can see here, miscarriage rates go from being 15%, 25%, 50% in your 40s, and then up to 90% or higher after 45, which is why most women who try to conceive later in their lifespan may encounter some trouble finding that golden egg with the right number of chromosomes. Another, and what I call the double whammy of female fertility, is that not only does the quality of the eggs go down over time, but also the quantity of the eggs. So this is a graph that shows your antral follicle count. I want you to focus here on this purple graph, which is the 50th percentile. It goes from 15 to 20 eggs, when you start your reproductive lifespan in your teenage years, and it progressively declines and declines, so that the average at age 40 is under 10 eggs, and then it keeps going down until you hit menopause. And that's when we say the bank is empty, there's no more viable eggs in the ovary. The average age for that happening is 51, but even though there might be some eggs in the ovary in your late 40s, the quality of those eggs and the amount of those that are normal are very small. So let's talk a little bit about the egg freezing process. You might remember this slide, I showed it to you. I said the pituitary gland talks to the ovary, and this FSH and estrogen feedback helps them communicate. What we try to do in an egg freezing cycle is we try to shut off the brain so that the pituitary is not involved, and we give you exogenous or injectable forms of this FSH hormone so that we make each egg in the ovary feel special and grow. So rather than growing one a month, we're growing multiple a month. And that number is very well correlated to the AFC or antral follicle count, and also to the anti-Mullerian hormone, which is a hormone that represents your ovarian reserve. What we do is that we have to give you injectable medications, so FSH and similar medications, for about 2 weeks or so. You inject these medications into your subcutaneous fat around your belly button. We bring you into our clinic and we do vaginal ultrasounds where we look at the ovaries. We do some blood work as well to track your estrogen levels and perhaps some other hormones, depending on the protocol. And we're making these follicles, which start very little, couple millimeters, grow. We can't see the eggs because they're microscopic, but we know that they're in there within those follicles. And then once they get to the right size, we give you a different kind of injection, which you'll hear called the trigger injection. This starts a final maturation process for those follicles. And then 36 hours later, we do what we call an egg retrieval, which we use the same type of ultrasound we use in the clinic, but we have a needle at the top of it. And under direct visualization, we can go into those follicles aspirated. So you can see on this one here, it's going right into the ovary and aspirating the follicles. And this is another way to look at it. You can see the needle coming from the top into that follicle and suctioning off all that fluid, and within that, the egg that lays there. We get that follicular fluid over to our lab, and our embryology team will look through it and then retrieve the eggs that are there. What this looks like for you on a calendar day, you usually have some medications that you take in the cycle prior. Usually come in with your period and then starts injections shortly after. You have ultrasounds and blood monitoring, maybe every third day, every second day, or every day towards the end, as we try to figure out the right and the optimal time to give you that trigger injection. And then 36 hours late, you have your retrieval. What happens at the retrieval? We get eggs that look like this. This is an egg surrounded by the cumulus complex. After a couple of hours, we clean that complex away and we can look at the eggs. Some eggs are going to be immature because they're too small to respond to a trigger injection, but we're seeking to get as many mature eggs as we can without, of course, making you sick or overstimulated. Once we get an M2 egg or a metaphase 2 egg, which is deemed mature, we can vitrify it and we can freeze it. And these eggs can stay frozen for a really long time until you need them. In the future, if you come back and you want to use your eggs, we would inseminate those eggs through something called intracytoplasmic injection. And then we would let them grow through all of these stages of development, 1 cell, 2 cell, 4 cell, until a couple hundred cells. And you can see this video up top, it's an embryo developing. And you can see it divides until it gets to the blastocyst stage. And usually that's when we would either biopsy them if our patients want to do genetic testing, or we would transfer them into the patient. And if we had anything extra, we could refreeze the embryo at that stage. But going back a little bit to the egg freezing expectations, this is a busy slide, but I like to have this information so that you can refer to it later. The number of eggs varies based on ovarian reserve, so that antral follicle count really matters. That's the number of eggs that we hope to get, and we try to grow as many as we can together. Only mature eggs can be frozen. The survival after freezing, it's pretty good, greater than 90%, but there's always a chance that 50% survive, and even that none survive. I would say in our lab, that's quite rare, but that's something that you kind of want to ask your physician and make sure that you understand there's no guarantee that the eggs will survive. And there's really no guarantees in this process at all. It's just about understanding the expectations and what might happen. You may need more than one cycle. We'll talk a little bit about this to achieve the number of eggs that you feel comfortable with. And like I said, no guarantee. The other thing I always tell my patients is like, just because you froze eggs doesn't mean that you'll need them. A lot of our patients are going to try to get pregnant 3, 5, 7 years later, and they can get spontaneously pregnant. So they don't necessarily need to use those eggs. It's not the fun way to get pregnant. I always tell my patients that if they need them, they're here for them, but they might want to save them for the second pregnancy or the third pregnancy, because conceiving naturally is never going to get easier. So if a patient can do it naturally, then they have more options for later on. A little bit about risk of egg freezing. Honestly, most people do quite well. The most common complaints are nausea, bloating, because the ovaries will grow, so you'll feel it. People feel fatigue, and sometimes there's a little bit of bruising at the injection sites. People ask me if there's an increased risk of ovarian and breast cancer. We've studied it. The answer is no. The procedure is pretty straightforward, but a 1% risk of complication being bleeding infection or injury to the things around it. I'd say that's pretty low. And then the other thing that I talk to all my patients about is about hyperstimulation. We use a special kind of trigger now that makes that risk quite low. It works in most patients. So something to keep in mind for patients that have a high ovarian reserve, which is a lot of our egg freezing patients, you want to manage that risk. And we take a very conscious approach at making sure we get as many eggs as possible, but never risking making you very sick. Small chance of that the ovary twist upon itself, but I would say that's a much less than 1% risk per cycle. So overall, a pretty safe procedure. So then let's move on a little bit to when to freeze. These are the questions that I have my patients ask themselves. They say, how old are you? When do you want to have children? What's your financial situation? And do you have coverage for egg freezing? How much do you care about biological children? Because you can always do IVF with a donor egg later on. And if your genetics are not important for you, then this may be less valuable. And then lastly, when can you spend 2 to 3 weeks in one place? So it does require that you're kind of in the area for a couple of weeks. And I know a lot of my patients have demanding jobs or careers that take them to different places every week. So I say we got a plan for a month that you can be around. This is a great paper that's literally hot off the press. My good friend Jen Backensen and in Feinberg over at Northwestern in Chicago published this cost effectiveness analysis. And what they try to do is to understand, does it make sense to egg freeze, or does it make sense to do IVF later should you need it? And I want to take you to some of the tables because I think they're quite informative. This is a table where they looked at how many eggs were frozen per cycle by age. So I think the main takeaway here is the number of eggs that you can freeze starts to drop off in your early 30s and then gets quite small by your early 40s comparatively. So you get about less than half of the number of eggs. And if you remember, 2/3 of these eggs are going to have the right number of chromosomes, and then 9 out of 10 of these eggs are not going to have the right number of chromosomes. So that makes cryopreserving in your 40s very difficult. The other thing that they looked at is from a cost effectiveness standpoint, if you want one kid, what happens when you freeze at 33 and then you try to get pregnant at 43, which is the strategy that makes most sense. They did that for people who wanted 2 children, freezing at 33 or not, and then starting to try at 40 through different strategies. I think the main takeaway, I won't go into all of the numbers, but what they found was that freezing at 33 was a cost-effective strategy, regardless of whether you want 1 child or 2 children. Of course, it's more expensive if you want 2, but you can look at the rates of success. So 73% chance that you have at least 1 live birth if you cryopreserve versus 50% chance that you do, and the cost is half when you're looking at 1 child. And then similarly here, 93 to 94% chance of having 1 baby, and then 60s to 70s of having 2. And then when the cost was in the 50 to 75 range, when you look at not trying to cryopreserve embryos or do egg freezing and then doing that later, you still have a pretty good chance of 1 baby when you start at 40, but you look at what it looks like for that second baby and you have 50% chance or even down to 20 for even a higher cost. So from a cost effectiveness standpoint, if genetic children is important, cryopreserving in your early 30s might be the right strategy. at least from a cost effectiveness standpoint. And then let's move into how many eggs do we want to freeze? And I think this is really important. The first concept that I tell my patients is not every egg will become a baby. And that's really important to know. The reason is that once you have a mature egg and you thaw it, you know that like 90–95% of them will survive on average. 80–90% are going to fertilize. So if you have 10, you're looking at 8 or 9 that are fertilized, and about half make it to the blastocyst stage. This is very much dependent on your age, your quality, the lab that you're working with. But you can see how very quickly from 10 eggs that you had frozen, you're looking at 4 embryos. And we know that based on age, not all of them are going to be normal. It could be 30% are normal, it could be 70% are normal, it could be somewhere in between. So you're looking for that normal embryo. Once you get a normal embryo, meaning the right number of chromosomes, you have about a 70% chance of implanting, depending on your lab and your clinic. That might be 60, that might be 80, but that's kind of what I quote my patients. So you do need a good amount of frozen eggs to be able to get to that healthy normal embryo. And then you usually want a couple, especially if you're looking for multiple children. This is another way to look at it. When you're looking at the chance of having a live birth. So this is a baby, taking a baby home. If you freeze at less than 30 for every egg that you have about an 8.7 chance. If you're looking closer to 38, it's about a 5% chance. And if you're looking at 43, 44, you have a 1% chance per egg. And that's partly quality, that's partly they probably won't have the right number of chromosomes. This is a chart that I love showing to my patients. And you can see here, if you freeze 15 eggs and you are a donor or in your 30s, you have a 90% chance of having a baby. If you freeze 15 eggs and you are 40, you have about a 40–45% chance of having a baby. And if you were 44, you can freeze 80 eggs and you still wouldn't be at 50% chance. So you can see age really matters. And of course, if you remember from the beginning, because the number of eggs in the ovary goes down over time, getting to 15 eggs for a 25, 30, 35-year-old might take 1 cycle, maybe 2, whereas for someone in their 40s, it might take 3 to 4 cycles. So that's why people usually advise doing this sooner rather than later, but not necessarily it's something that everybody should do right away. This is another calculator that I really love. And I took some examples here to show you. So this is the probability of having 1, 2, or 3 children when you freeze 15 eggs. So when you're 35, you have an 83% chance of 1 baby, 50 of 2, and 22 of 3 babies. When you do this at 40, you have a 42% chance, then 10, and then 1%. And if you do this at 44, you have only an 11% chance and very unlikely that you'll get a second baby. This is just another way of quantifying. And I do this with couples that I work with to try to understand, do we want to freeze more? Do we not want to freeze more? I do it with women who did 1 cycle and they're trying to decide, is this good enough? Do I feel comfortable with my numbers? What I'll say to all my patients is there's no magic number that you need to freeze. We can help you understand your probability of success. But in this case, a 35-year-old with 15 eggs, 83 out of 100 are going to have a baby from these eggs, but 17% will not. So if you really don't want to be in that 17%, you might want to do another cycle. Someone might say, hey, 83 is wonderful. I don't want to do anything else. And if it doesn't work out, I'm fine with that. I did my duty. I feel good and I can go on knowing that I have this stored for the future. So that's just kind of how I counsel my patients. I think it's a very personal decision as to how many eggs you want to freeze. And as physicians, all we can do is support you and educate you in making that right decision. So going back to the recap, we talked a little bit about why people pursue egg freezing. It's to improve the chances that they can have a genetically related child in the future. It's not a guarantee, but it definitely changes that probability. And we've seen more and more patients who, are not ready to have babies, have not found the right person to have babies with, have a demanding career, have, health issues that they want to deal with first, or just generally want to feel good about having that backup, are doing more and more egg freezing. So also it's certainly a group of patients that I very much enjoy taking care of. We talked about the egg freezing process. We talked about the right time, and then we talked about how the number of eggs that you need changes based on your preferences and how to start thinking about that right decision for you. So thank you so much for your time and for listening. My name's up here. I work in the Bay Area. Happy to see any patients who might want some help with egg freezing, but I also have outstanding colleagues throughout the country and happy to connect you with any of them. I'm on social media, Instagram, Facebook, LinkedIn, and this is a photo of our group. We have a great group of physicians very committed to taking care of patients of a variety of backgrounds, with problems, without problems, for egg freezing. So happy to help anyone in need. Thank you so much for your time, and then reach out if I can help in any way. Take care.